Welcome to Assessing the Thorax and Lungs. This is part 5 of health assessment. This body system is very important to assess correctly because we cannot live without our lungs and heart working well. This PowerPoint is going to focus on how the normals are assessed of the thorax and lungs. The abnormals are really going to be discussed in the respiratory section of this course later on, and the heart and circulatory system and how we assess those are going to be in a separate PowerPoint. As I mentioned, the thorax and lungs are very important for our bodies to live. Well, when we think of the thorax, we have ribs, lungs, and muscles used for breathing. The heart and the circulatory system is separated out, even though those also live within the thorax. Like any other body system, we're going to start with our interview. We want to ask if they have any chest pain, any chest pressure, or difficulty breathing. We ask those first. If they answer yes to any of those questions, we know we have a major issue and we need to focus on that major issue right away. We also want to ask if they have any history of trauma to the ribs or to the chest, or any chest or lung surgery, if they currently smoke tobacco products or if they did in the past. We also want to know if they have any lung diseases or if anyone in their family has lung diseases. We also want to know if they have any occupational or environmental exposure to harmful chemicals. And honestly, there are so many more questions that we could ask, and those are going to be covered in our respiratory lecture later this semester. When we inspect the thorax and lungs, we're watching to see if their chest moves symmetrically with each breath. Both sides of the chest should move the same. We're watching to see how easily they are breathing. Do they look comfortable while they're breathing, or do they look like they're having some difficulty breathing? Do they look like they're trying really hard to breathe? While we watch, we count respirations and watch the rhythm of their breathing. Is it coming regularly like a metronome, or are they breathing irregularly? We want to assess how deep or shallow they're breathing. We also want to look at the color and shape of their chest. The skin color should be the same as the rest of the body, and the chest should be shaped like a V, sloping down the V as we move from the shoulders to the chest. Now be mindful that there are many variations in body shape, so when we're looking at the chest, we need to know that not everybody is going to be the same and not every single person is going to look like a V. We also want to look at the back and the front width of the chest, just like this picture here shown on the side. If the chest is thicker than it should be, they may have a barrel chest, which is abnormal. Remember back in the skin PowerPoint when I said we would assess skin everywhere? Well, this is a body system where the lungs can affect the skin color all over the body. If the lungs aren't working well, the skin can turn blue or cyanotic. The skin can become cool and clammy instead of dry and warm. The sclera, conjunctiva, and mucous membranes may become pale and cyanotic if the lungs aren't working properly. Chronic lung disease can cause the nails to be a clubbing shape, and capillary refill of the nails may be slow. So now we have a body system that shows some assessment findings in other parts of the body. I can teach body systems as a singular system, but the body is all of these systems working together, so alterations in one will affect other body systems. We haven't discussed the brain yet, but alterations in lung function may affect the brain as well, and we have more of that coming later. We don't normally palpate or percuss the lungs as normal nurses. These are advanced skills, but sometimes we need to. There have been times where I've palpated a thorax for tenderness after a fall or if the patient complains of pain in one area of their chest. We also should be palpating the chest for temperature, but there usually isn't a major change in temperature of the skin and the thorax and the rest of the body. I've also palpated the chest for symmetrical expansion if I was questioning what I was seeing. This is done by placing both hands on the patient's back as shown in the picture. Note the distance between your thumb, and as the patient takes a deep breath in, you're watching your thumbs to see if they are expanding the same. This may help you determine if the chest is expanding equally. But like I said, I only really do this when I'm not sure the chest is really expanding equally and I want to make sure because I can't tell if it is or isn't. If the chest isn't expanding equally, there's a problem. Auscultating lung sounds is the most common assessment we do as nurses. We should be assessing lung sounds in every patient. Thorough assessment of lung sounds can find abnormal sounds that will absolutely help us determine what's going on with our patient. What we're auscultating is the airflow within the respiratory tract, the air moving in and out. To auscultate, we use our stethoscope and we systematically listen to the lungs on the anterior surface, posterior surface, and the lateral surface. We listen through inhalation and exhalation in each location, in and out. If we only listen to inhalation, we're going to miss sounds that only occur on exhalation. Now let's look at this picture. The lungs start just above the clavicles and extend down to the diaphragm. The right side has 3 lobes, upper, middle, and lower. The left side has 2 lobes, upper and lower. The middle lobe area is taken up by the heart. The lungs fill up the whole chest, which is why we have to listen to so much of the chest to hear the sounds everywhere. Listening to lung sounds is a very systematic process. We follow the same process on every patient. We're going to start anteriorly, just above the clavicle, and work side by side down the chest. Look at the right side of the picture shown. We go side to side, noting the sounds we hear on each side, comparing them as we go. We're checking to see if the right side sounds like the left side. We move all the way down the ribs and all the way down those lung fields. Next, we go to the posterior side and we start at the top of the back and work our way down side by side until there are no more lung sounds, comparing each side just like the left side of this picture. Again, we're checking to see if the 2 sides sound the same. Lastly, we check each side laterally in 2 to 3 locations. I normally ask my patients to raise their arms up a little bit so I can get my stethoscopes on their sides easier. Again, we're comparing side to side to make sure that they sound the same on each side. Our lungs have different sounds depending on where on the chest we're listening. The first normal lung sound we have is bronchial. Bronchial breath sounds are sounds located over the larynx and trachea, and they're high-pitched, harsh blowing sounds that are longer on exhalation than inspiration. They are colored yellow on this picture on the right. The next normal lung sound we have is broncho-vesicular breath sounds, and they sound medium-pitched, blowing sounds that are heard over the large airways in the lungs. They are equally long for inspiration and expiration, and they are colored purple on this picture on the right. The last sound we have is vesicular, which are soft, low-pitched sounds heard over the majority of the lung fields. Inspiration is longer than expiration, and inhalation is higher pitched than expiration, but they sound not high pitched in general. Like it's higher pitched, but it is not a high pitched sound. Next, we have our abnormal or adventitious lung sounds. We have a couple types of adventitious lung sounds: crackles, wheezes, rhonchi, friction rubs, and stridor. Crackles, also called rales, are non-musical sounding noises that are discontinuous, meaning they don't happen continuously during the ventilation cycle. Crackles sound almost like Rice Krispies popping in milk, or if you take a couple of strands of hair and rub them together with your fingers right next to your ear. We normally hear these sounds on expiration, but they could occur in exhalation as well. What we're hearing in crackles is closed alveoli popping open if they have collapsed, or we're hearing fluid inside those alveoli that's filled up inside of there, like in fluid overload, pneumonia, or obstructive pulmonary diseases. We can classify crackles as fine, medium, or coarse, and this really goes to how loud they are. Fine crackles are soft sounding and they're easy to miss, usually occurring in mid to late inspiration. Coarse crackles are much louder, they're hard to miss, and they may be heard throughout the entire inspiration. Wheezes are continuous musical sounding notes that can be heard on inspiration or expiration. This is when we must auscultate lung sounds during inspiration and expiration. Wheezes are associated with narrowing of the airways, like asthma or partial airway obstruction. The musical sound is the air squeaking its way through the airways. Next, we have rhonchi, which are actually classified as a type of wheeze, but they're associated with secretion or fluid in the airways, not like crackles where there's fluid in the alveoli. The rhonchi noise is the secretions moving in the airways with that air movement. They're usually low-pitched, sounding like a rumbling or a snoring, and they oftentimes clear with coughing. If you ever got sick and you're breathing and you could feel and hear the junk moving in your lungs and you're like, oh, I just need a cough to get this to stop moving, that's rhonchi. Next, we have friction rubs. These sound like a rubbing or grating sound, and they're usually heard during inspiration and expiration. They're usually the loudest in the bases of the lungs, but sometimes they can be heard all over the lung fields. These sounds will not clear with coughing and will usually not be present if the patient holds their breath. Friction rubs are caused by inflammation of the pleural membranes or if there's a loss of lubrication between the pleural membranes, and these friction rubs can be very painful. Lastly, we have stridor. Stridor is a high-pitched musical sound heard over the trachea of the neck. It's associated with severe narrowing of the trachea and anaphylaxis, and it requires immediate intervention. A person with stridor cannot get enough air in or out of their lungs, and their trachea may be completely swelling shut, stopping all airflow. Since Block 1 focuses on adults and older adults, it's important we discuss some thorax and lung changes that are common in older adults. First, it's common for older adults to have wider, more barrel chest-like shaped chests. We call this increased anterior-posterior diameter. They also have more curved older spines, or kyphosis, where they bend over more from the top of their back, almost hunchback-like. This can affect how well they breathe. They also have decreased expansion of their thorax when they breathe, so they may not have big, deep breaths like adults do. And they also may use accessory muscles to breathe, like their diaphragm and belly breathing. These can be totally normal for older adults, but if it's a new change for the older adult, it should be investigated. And this is the end of part 5 of health assessment.